Go live now.
Yeah.
Go live.
Yeah. Good evening, all seniors and all doctors. I take this opportunity to welcome you all behalf of Hetero Healthcare. My name is Devendra Muraskar. I am the marketing head, Hetero Healthcare for Hillian Division, a division of Hetero Healthcare, CNS. First of all, thanking you for joining us today to discuss on Cariprazine topic. As you know about the Hetero Healthcare, we are the largest R&D wings with having 360 solution provider, more than 25 years of excellence in multiple therapies, currently present in more than 126 plus countries worldwide, more than 200 products across various therapeutic categories such as CNS, HIV, AIDS, onco, cardio, and neurology and psychiatry. Distinction of bringing 4 biosimilars products into the market, India pharma business, 36 plus state of art manufacturing facilities, and pioneering in quality and innovation. So today we have the eminent Dr. Mahesh Gowda as a chairperson and moderator. Sir is a consultant psychiatrist at Spandana and director of Spandana Healthcare based at Bangalore. Sir, as a direct council member of IPS and honorable past editor of IIPP, past treasurer of IPS Karnataka, and sir is having more than 70 publication in Index Journal. So I request sir to please share your experience and discuss more on the subject. Sir, over to you now, sir. My sir.
Thank you so much. Good evening, everybody. And I'm happy to be back with a new discussion on the same molecule. We've been talking about Cariprazine for a year's time now. We've had some experience of using this molecule, but we need to know more and more about this molecule to get the confidence about utilizing this molecule in clinical practice. Today, we have Dr. Sagar, who's going to talk on clinical utility of the molecule Cariprazine. Dr. Sagar is a faculty at Department of Psychiatry, Sion Hospital. He's an assistant professor. At a young age, he's made a great mark in academics, research, and also publications. Dr. Sagar has also held administrative posts, and he's worked at Indian Association of Biological Psychiatry. He's been with the Bombay Psychiatric Society, also as the EC member. And his contribution to the society at professional level also has been great. Today, in his own style, in a very crisp way, he's going to talk about the molecule Cariprazine and the clinical utility. Over to Dr. Sagar.
Thank you, sir. It's always a pleasure for me to talk on any molecule because psychopharmacology is my area of interest, and today I am getting a chance to talk on this molecule, which is a wonderful molecule, that is Cariprazine. So we will directly come to the point and not waste much time, and I will share my presentation on clinical utility of Cariprazine. So what I have done is I have done this in the form of cases only. So clinical cases, actual cases which I have seen. As the saying goes, many of them say, practice what you preach. But what we follow is we preach what we practice. So there is a disclaimer here that whatever presentation I am making today is purely based on my clinical experience, and actually what the patient says and what the patient responds, that is what I have presented here. So sometimes when I make such presentations and some people ask what is the reference for this using and all. So sometimes we don't have reference. It is just the clinical evidence and the patients are our reference. So yes, with this disclaimer, we'll start the presentation. I'll take around 15 to 20 minutes and gradually we'll understand where all we can use this wonderful molecule. Any new molecule comes, we have a lot of many questions in our mind. Any new molecule launched, we have this question. So when Cariprazine is also launched, I think it is almost more than now 2-3 years we have been using this molecule. But still there are some questions many clinicians ask, which all indications it can be used. Because US FDA gives couple of indications where it can be used, but we use any molecule when it is launched in an off-label indication. So I'll be discussing on these points where all it can be used apart from the US FDA approval indications. Can it be used as a monotherapy, or it has to be used as a polypharmacy or as an add-on molecule? That also will make it clear. How the dosage titrated, because many of the times in a bit of hurry, we directly go to higher doses and then we get a lot of side effects. So how it should be titrated? What are the common side effects observed? Now comes the main points, whether it can be used in children and elderly population, whether it can be used in pregnancy. It is approved for bipolar depression, so whether it can induce the switch to mania, and how long this molecule can be continued in the patient. So these are roughly questions in my mind and many of the clinicians' mind. So we will present some cases and I think we'll answer many of them. And in the end, we'll take the Q&A if something is left. So let's start with the few cases, clinical cases. So moving on to the first case. You all will agree that any patient we see in our clinic, irrespective of the diagnosis, irrespective of the age group, right from the 3 years age children or 6 years children who comes with behavioral issues or hyperactivity, and we start medications, and whenever the patient is and the relatives are leaving our chamber, in the end they will ask one question. डॉक्टर इसका शादी तो अच्छे से होगा ना, and these medicines will not have any effect on his married life. Means irrespective of the diagnosis, irrespective of the age, this question is always asked by the relatives because they are very much worried about the marriage. So let's see our first case. She is Puspa, a 23-year-old female. She is taking treatment from me for her diagnosis of schizophrenia since long. And almost 8 to 9 months she was under my treatment, and she was well maintained with olanzapine 20 milligram in divided doses, haloperidol 10 milligram, and triaxiphenil 4 milligram. So this is our routine prescription in majority of the patients suffering from schizophrenia, and they all maintain well. She was also maintaining well for more than 6 months. Now her marriage was getting fixed. So relatives were concerned that now she is getting married. So doctor, what is happening? That with olanzapine, she has gained a lot of weight and it is causing sedation, because I had given olanzapine 10 milligram twice a day. So they said, ki now, sir, she will be getting married and she will go to someone else's house, and if she sleeps the whole day, it will look bad. So kindly help us in such a matter. So I said, yes, we can definitely do. And this molecule had newly launched. And I clearly remember this patient because she was my first patient on which I had tried this molecule. So I said, we will shift her from olanzapine to another molecule, that is Cariprazine 1.5 milligram. So I added this molecule, and I then gradually tapered the other antipsychotics. So first olanzapine was gradually tapered, and then later on haloperidol was also gradually tapered. And then she was taking Cariprazine 1.5 milligram, which was up titrated to 3 milligram. And she continued with that 3 milligram Cariprazine, and for more than 6 months, she was much better. She got married also, and there was no sedation, no weight gain, and she was doing pretty well. But fortunately or unfortunately, she went for her honeymoon at Australia. And from me, she had taken 2 months medication, which she carried along with. After 2 months, the stock got over, and she was still continuing staying in Australia, and she could not refill the prescription. So 1 month, she was off medications there. She came back to India. It was still pretty going well, but after a couple of months, she again had the relapse of her schizophrenia illness. And then the relatives were immediately brought to me, and I asked since when she had stopped medicines. So almost it was 2.5 to 3 months, and I said no, again we'll have to go back to the treatment. And I again started this patient on olanzapine and haloperidol, because for me, if the patient has responded well, and in acute stage, again, she had delusions, hallucination, aggressive behavior, decreased sleep, I said, we'll go back to the previous molecule. Once she is stabilized, we'll shift to cariprazine. And this time I warned her, please don't stop medicines. And now it is almost 2 years. She is taking only cariprazine and she is doing well. So the first indication where we can use cariprazine, as we can see from this case, a maintenance phase of schizophrenia, wherein the patient has done well, she is stable and everything is good, and we want to maintain the patient on a low dose antipsychotic with minimal side effects, we can shift over to cariprazine. Second thing, what we can see from here, that she was continued even after stopping the medicines for almost 2 months, she was doing well, because cariprazine is a longer acting one, metabolite is a longer one, so she was able to maintain. So in maintenance phase, if the patient skips couple of doses, we are still not worried much, but then we have to insist that please medicine has to be taken continuously. So that is our first indication, maintenance phase of schizophrenia. Moving on to the next case. Now here, this was also, I clearly remember this patient because he was my next couple of patients whom I had start. He was a 58-year-old male, a diagnosed case of bipolar mood disorder with psychotic features, and under my treatment, he was pretty stable with risperidone 4 milligram, quetiapine 50 milligram, divalproate 1000 milligram, and triaxipinil 4 milligram, and doing much better. But unfortunately, he went into depression. Now almost it was 2 months, and he has this complaints of depression. And we all will agree that bipolar depression is much difficult to treat than bipolar mania. See, we can control the manic episode, but once the patient relapses into depression, it sometimes becomes very difficult. So he was also very difficult to treat. I tried multiple medications, a lot of permutation combination, adding lamotrigine along with divalproate, and various quetiapine SR also was tried. A lot of things was done, but he was not coming out of depression. And this molecule was newly launched as a bipolar depression US FDA molecule. So I added tablet cariprazine along with his previous molecules like risperidone and divalproate. 1.5 milligram. After 2 weeks, it was increased to 3 milligram, and he was pretty doing well. Quetiapine, he was not tolerating, so we had stopped later on. And then after cariprazine, he said I had some sleep disturbances, so we added zolpidem with melatonin combination, and now he is almost more than 6 months, 8 months. He is doing pretty well. So the other indication where we can use this molecule is bipolar depression. And this gave me a lot of confidence. And in my clinical practice, I prefer cariprazine using more in depressive patients rather than schizophrenia. I'm more comfortable using in depressive episodes because it works well in depression, unipolar, be it bipolar, and it is working well. So this is the second indication, depressive episodes, where this cariprazine can be used as an add-on prescription with our other medications. Moving on to the next case. Again, now this is something unique case we should remember. Now he is a 41-year-old male. He's a case of schizophrenia and under my treatment, and he is doing well on clozapine. He is not tolerating other medications. He had some EPR also in the past, and with clozapine he is doing well, 100 milligram, and no psychotic symptoms for more than 6 months. But the only concern which the family members had expressed that he has lot of sadness of mood and no enthusiasm to go out or work at home. Means anything if he is asked to do, he doesn't do. He just keeps sitting in his house, in his room, and not doing anything. And also they observed that he had a lot of memory issues also. Means whatever they are telling, he's young and he's not listening. There are a lot of cognitive issues. So we all are aware of this cognitive residual symptoms of schizophrenia where we don't have much options. So I said, let's try. We added tablet cariprazine 1.5 milligram, which was increased to 3 milligram along with clozapine. Clozapine was continued, and gradually the patient started feeling better and started doing at least simple work as advised by the family members. And now it is more than 1 year, he is doing well. And the family members are happy that at least he's go out of the house, does some physical work like going in the bank, bringing some groceries and all. At least that he is helping in the household chores. So that is the advantage. And another indication where we can use cariprazine in residual symptoms of schizophrenia, particularly like these depressive symptoms or cognitive symptoms which are left in the patients. And here I have said that he was on clozapine. So theoretically, the combination of clozapine and cariprazine, it has got an added advantage and it works well in such patients. Moving on, so these were our classic cases. Now we can go on to some offbeat cases, off-label cases also. So let's move to the next section of our presentation. So he's a 17-year-old boy. Now he was suffering from obsessive compulsive disorder. So routinely we start treatment with SSRIs, and he was also given tablet fluoxetine 20 milligram, which was gradually up titrated to 80 milligram. But still he was not responding much. And there were a lot of anxiety. So usually I had some or the other benzodiazepine. So he was already on tablet oxazepam, 30 milligram in divided doses, which was gradually up titrated. But still there was no improvement in OCD symptoms. So usually we add clomipramine along with it, but he did not tolerate clomipramine. He had a lot of sedation and constipation. He said, no, you give something else. So tablet memantine was added 10 milligram, which was updated to 20 milligram. But still that OC symptoms were not going to 100%. He was only getting 40 to 60% better. So usually we had some low dose antipsychotics, and here I added cariprazine. Usually in OCD, I prefer personally aripiprazole, but somehow in this case, this was a new molecule. So I said, let's They both belong to the same category. Let's try Cariprazine and see. And Cariprazine 1.5 milligram was added, and he was much better. And now it is almost 2 years he is taking, because in between, once he was well maintained and OCD was 100% improved, I started tapering the dose, and when Cariprazine was removed, he again relapsed. So then he insisted that we keep Cariprazine, and he will be willing to continue the medication. So he's almost more than a year, he's taking this fluoxetine, Cariprazine, and Exozep, and doing pretty well. So as an add-on therapy in OCD, this Cariprazine can be used. But again, personally, this is an off-label, off case. Cariprazine I have used in OCD. First choice would be always aripiprazole, and second I would prefer Cariprazine if the patient is not tolerating other antipsychotic. Moving on to the next case. Now coming to the pediatric case also. So he is actually 23-year-old diagnosed case of intellectual disability. Basically, he had a lot of behavioral issues, and the relatives was very much worried with his behavioral issues, like hitting family members, shouting in between, throwing household articles. And intellectual disability patients have sometimes these suspicious behaviors, like suspicious that family members are against them and all. So for which we started tablet risperidone twice a day, 2 milligram, up titrated, but he was not getting better. So shifted to olanzapine, but olanzapine was causing lot of weight gain, and relatives said कि वो खा के फूक गया है. So please do something, that he doesn't eat much food, and already behavioral issues are causing a problem for us, and now his appetite is also causing a problem. So then I said there is one option of Cariprazine which can be given to this patient. So Cariprazine 1.5 milligram in the morning was started, and he responded well. And he's only on Cariprazine now 1.5 milligram and doing well for more than a year. So for intellectual disability with behavioral issues also, we can use Cariprazine. Here he is a bit older child. I have some patients of younger age also. I think the youngest child which I have given is 8 years, where Cariprazine was given, and for his behavioral issues, and he has done pretty well. So, but yes, this is one more options which we can use in ID with behavioral issues. So that is one more indication. So these are some 5 cases where all I have clinically used. I would just run through some other indications also. So yes, we all know it can be used in schizophrenia, and I will just add on to it that it can be used in all kinds of schizophrenia, like schizophrenia maintenance phase, schizophrenia acute phase. Particularly, it responds well in negative symptoms. Positive symptoms, what I have seen is you have to give at a higher dose, like 4.5 to 6 milligram. But I am pretty not comfortable in positive symptoms. I prefer in negative symptoms or resistant cases of schizophrenia. Theory we'll skip. Another indication is bipolar mood disorder in depressive phase. Bipolar mania, there is not much response, because you will have to use at a higher doses, and there are not much literature. There are some case reports where Cariprazine can be used in right from depressive symptoms to manic symptoms of bipolar spectrum, as I said. But then again, in bipolar mania, you have to give at a higher doses, and which I'm not comfortable, because we always start with the lower dose, and it can induce mania at a lower dose if patient is prone to go into mania. MDD, yes, I have used clinically well, and I'm very much happy of using Cariprazine adjunctive to our antidepressants, where 1.5 mg to 3 mg works well in major depressive disorder. Substance use along with psychotic features. This is one of the indications where we can use Cariprazine. I have not used clinically much, but yes, there are some case reports where it can be used in cannabis along with psychotic symptoms, and patients have found good response. Again, bipolar with substance use, it can be used. There are no case reports in pure substance use which I have come across, but yes, with this comorbid condition, it can be used. Yeah, this is one of the indications where I am very happy to use, that is the borderline personality disorder. Because these borderline personality patients will come, they will always say, don't give lithium, it causes acne to me. Don't give me valproate, it is causing hair loss, it causes weight gain. They might plan pregnancy, again, that is an issue. So they have a lot of troubles, and they must have read a lot of medication. They will say, don't give such olanzapine, fluoxetine and all. So in such cases, Cariprazine is a good option. Only one tablet, long half-life. Anyways, this borderline personality disorder are sometimes non-compliant to medication. They might skip in between. So long-acting ones, preferably, it's good one. So I have used this molecule, and it's like a acting on all the symptoms of borderline, like impulse control, mood swings, micropsychotic episodes, everything gets controlled with cariprazine. So yes, it is a good option in borderline personality disorder. OCD we have discussed in my cases, but again I said I prefer aripiprazole. Yeah, coming to the elderly patients, particularly dementia with behavioral issues, I have used in some patients where we can use cariprazine because there are some benefits like once a day dosing, less anticholinergic side effects, less sedation, less metabolic adverse events, no sexual side effects, and relatively few drug-drug interaction. So it is pretty safe in elderly patients, no risk of falls and everything, and patients responds well. Children and adolescents, yes, it can be used with bipolar psychotic disease in children. Or another indication which I discussed was intellectual disability and autism spectrum disorder with behavioral issues, where I have clinically used and I have found good results. This is one of the study where they have used in ASD and ID, but then again the number is misleading. Like only 2 patients are of 15 age, rest all are above 20 only. So 30, 34, and 37. But still clinically we can use in children with behavioral issues of ID and autism, and patients have responded well. So dosage, as I said, we have to always start with 1.5, but in mania patients, you will have to go to higher doses up to 6 milligram. In schizophrenia, 4.56, basically for the positive symptoms. The negative symptoms responds well to lower doses. In bipolar depression, 1.5 to 3 is the dose which I have used. Side effects, mainly akathisia is there, which needs to be taken care of. But in my majority of the patients, they have tolerated well because I always use benzodiazepine freely, and as an add-on prescription, it will be there in many of the patients. So chances of akathisia in my patients are very less. EPR, I have seen couple of patients having rigidity and uprolling of eyeballs, which responded well to our routine treatment. Insomnia is the main side effect, so that's why majority of the patients are given morning medications. Couple of them have complained of dizziness and sedation, so I have shifted them to night, but majority are in the morning. That's common side effects. So yes, in the end, I will again go through. So where all it can be used, we have discussed. Can it be used monotherapy, polytherapy? Answer is clear. Yes, if the patient is maintaining well, so you can use as a monotherapy in maintenance phases, but it can be used as an add-on in various indication. Dosage titration we have discussed. Common side effects we have discussed. Safely, it can be used in children and elderly. Pregnancy. Now, yes, this was a big question. No studies gives us answers, but my couple of patients got pregnant and they were on cariprazine. They did not inform me. So, but luckily they informed me after 3 months and all, and everything was fine. Their USG was fine. Recently, that one of the patient had delivered the baby and he was healthy. But after 3 months, I did not take chance. Now they had informed, so I said, please, we will shift over from cariprazine to a safer antipsychotic, which we know, when they had willingly done so, and she was well. But then 3 months she continued in pregnancy. And there is one case report also which I have seen, which has been published already, that cariprazine was continued in the pregnancy and the patient delivered well. So yes, directly or knowingly you might not start in pregnancy, but if the patient gets pregnant, and then you need not worry, it is not caused much trouble till date. Can it induce mania? I have seen couple of patients of depression wherein I have added this and they had switched to mania, because we start with 1.5, and for mania you have to use a higher doses, which has not been done directly on day one. How long it can be continued? Till the patients required, and you can see in my many of the cases they have been over more than 1 year. They have continued cariprazine and doing pretty well. There are no long-term side effects which have been seen, and patient is well tolerating this molecule. So I think that answers our question. These are a couple of references. So start every day with a new hope, leave bad memories behind, and have faith for a better tomorrow. And we also have faith for this molecule that it is doing well. So thank you.
Thank you, Dr. Sagar, for a wonderful presentation.
Thank you.
It is really, again, innovative in so many ways. You made sure that the person went through the process of marriage very safely. That's very unique of your presentation. We'll come back to questions later. Now we'll request Dr. Suji Sakel, our second speaker. Welcome to Dr. Suji Sakel. Dr. Sujit is a faculty at the Department of Psychiatry at Calcutta. He's also the journal editor. The IJP journal is a very popular journal, and he's the honorary editor for this journal. He also has his name on the Indian Journal of Psychological Medicine. He's had multiple books which he has been an editor, and he's been an active part of the publishing house at the Indian Psychiatric Society. His research interests have been suicide, and he's been an active member contributing at administrative level also in multiple organizations. Today, Dr. Sujit is going to talk on newer aspects of cariprazine. He's going to talk on merits and demerits of cariprazine as a molecule. Over to Dr. Sujit.
Yeah, thank you, Dr. Mahesh. And basically, I think Dr. Sagar has covered uh, most of the essential elements. And I think what is more important is that I will just highlight a few points and not formally present slides. So, certain areas which I wanted to highlight specifically regarding cariprazine, especially again mostly based on the experience of what I have gathered by using cariprazine. So basically, one thing is that the dosage and the titration. This is actually, I will try to highlight those parts which have not been mentioned, or rather not much covered by Dr. Sagar, because he has covered most of it. So one part which I thought was essential in discussion, which has come out in uh, my clinical experience with cariprazine, is that initially when it was launched and it came in the market, there were too many companies which were vying for it, and there was a kind of sudden surge in use. And many of the uses where people were using it in all kinds of indications, and there was one a typical habit of titrating it to higher doses very fast. So probably people were shifting it up to 3 mg in within a week, and that caused a lot of discontinuation, primarily due to side effect, primarily akathisia. So this is one area which I thought that as time passed by, as we all grew up and actually waited and watched, we what we realized is that for our patients, the classical recommendation of titrating to 3 mg very quickly is something which would not have actually borne fruit. So basically nowadays, what is usually being done, what I prefer, is at least to continue for 7 to 10 days. Even if I am, as Sagar was saying, that if I am dealing with somebody with positive symptoms and I am planning to achieve a target dose of say 3 mg, so I would not hurry up to titrate it to 3 mg within 7 days. I would at least give it a 7 day to 10 day trial and then go to 3 mg. Usually, this almost definitely prevents the occurrence of akathisia. So, this is one area which has to be kept in mind. This is number one. Number two, being a long acting drug, as the half life keeps increasing, very often we get desirable results in positive symptoms even at 3 milligram of cariprazine, and we won't always have to titrate it to 4.5 mg. So I think, for example, in case of a positive symptom, even if I'm using it for the first time, we can always use benzodiazepines to control the agitation. But if you talk about cariprazine as a monotherapy antipsychotic, I would still prefer starting at 1.5 mg, waiting for at least 10 days, and then titrate to 3 mg. This time, when I titrate it to 3 mg, I would probably wait at least for 3 weeks, because many a times what we see that cariprazine takes a little longer to exert its action, but when it does, it often does in 3 mg also. Although there are patients where I have gone up to 6 mg, but the number of patients in positive symptoms also where I had to go up to 6 mg is not very long. I mean, the list is not very long. Mostly 3 to 4.5 mg for positive symptoms. That is my experience. And obviously, as Sagar was saying, for those with bipolar depression or in case of negative symptoms, I think 1.5 mg works very well. So this is primarily what I wanted to talk about, that either speed of titration and waiting at lower dosage or 3 mg for response. These are the two things. And number three, definitely the first case, as Sagar was discussing, I have been successful in keeping some of my patients who were maintaining well on olanzapine or risperidone monotherapy, and they, over a period of time, they develop metabolic side effects, and then they were very slowly uh, titrated. I mean, cariprazine was built up, maintained at 3 to 4.5 mg, whereas it was gradually, the risperidone or the olanzapine was gradually cross-tapered, and they have been maintaining well on cariprazine and minus the metabolic adverse effects. So this is one area where I think cariprazine has done well in many of my patients. So slow dose of titration, relatively lower doses, putting up the desired effects in positive symptoms also. And number two, maintenance. Number three, this is one part which I would rather say it's a classically experiential thing. It's not something, which would be considered academic, but I think maybe Dr. Mahesh and Dr. Sagar will also give their inputs, which can be a useful thing for clinical experience. There are a subgroup of patients of I'm talking about schizophrenia, who go for OPD based treatment, who are not adequately responding to a fair trial in terms of dosage and duration of two antipsychotics. So, for example, you start off with olanzapine, doesn't do respond adequately, and then you add haloperidol, gradually taper down olanzapine, not adequate response. I'm not talking about tolerability. Supposing they tolerate both the drugs well, but they do not respond. Usually, the classical practice has been that if possible, one can go to clozapine. But as many would agree that clozapine has many problems. One of them is regular monitoring of blood levels, TCDC and all that. So people are actually reluctant to do that. This is one problem. In other cases, there is issues with sedation also. So despite clozapine being the so-called boss in resistant cases, sometimes we think of probably trying a third molecule which is probably a little different in mechanism of action, which probably will work better. So after a fair trial of a two atypicals, or at least one typical, one atypical, there are certain cases where you would like to chip in a molecule and see if it works, because if it works, it will solve many a problem, including issues with compliance and patient harassments and all. This is one area where cariprazine has helped me, at least with 4 or 5 patients. Saying, so they were not classically, they would have probably gone into a clozapine trial, but uh, fair trial of cariprazine, one responded to 4.5, and most of them responded to 4.5. In one case, I remember, had to go up to 6 mg, but slowly, but nonetheless, they responded, and actually, it was classic. They were actually documented cases of resistant schizophrenia, wherein there was a step between clozapine and the two trials of antipsychotics, and I got satisfactory response with cariprazine. So these are some of the areas related to cariprazine, wherein I thought that I should, highlight, apart from whatever areas Dr. Sagar has so nicely, kind of illustrated. And I feel cariprazine has many similarities to aripiprazole in terms of clinical response profile, in terms of, the kind of dosage that we should begin with. Start from the lowest possible dose, wait, don't titrate it fast, because it may lead to, akathisia and undesirable side effects. So some of these things, also the fact that there was an initial surge of use, led to loss of popularity because many dropout, side effects, undesirable effects. So ultimately now when we are seeing a second gradual surge in cariprazine use among clinicians, we are seeing a lot of positivity after the initial drop in use. So I feel these are some of the areas which I thought I would highlight, uh, and I again thank Dr. Mahesh and Dr. Sagar for their inputs and introduction. So please, over to Dr. Mahesh and the team to carry on the discussion. Thank you.
Thank you, Dr. Sujit. That was a very insightful discussion on titration of this molecule. I thought we'll take few questions. I have few questions on the chat bot and few questions of my own. Dr. Sagar, since you've always been successful to get the young, unmarried woman with schizophrenia married with comfort, I want to talk about your experience of continuing this continuing this molecule in case they get pregnant, and also if there's any issues concerning pregnancy or lactation related issues.
Yeah. So as I said, that a couple of my patients had got pregnant on cariprazine also, and they continued for almost 3 months, 4 months without informing me. And after they have informed, I have not asked them to continue. I explained them that cariprazine in the later stages would not be recommended by me scientifically in case it will have some interaction with the prolactin levels and all, and it can lead to some abortion. So it's better to shift over to a safer antipsychotic, which I would prefer. And they have done pretty well. But see, it is almost 3 months later they had informed, and the baby was already formed and all, and they had done sonography, and also there does not have any teratogenic effect. So basically, it is safe that wise, but then we know that hormonal wise, it can because cariprazine is similar to aripiprazole, wherein it can reverse the metabolic side effects of our antipsychotic. So in some of the patients, where with olanzapine, if the patient has gained weight or having some increased appetite, have added cariprazine, and this metabolic side effects has gone down, similar to what we do with aripiprazole, like antipsychotic induced amenorrhea, we give aripiprazole, and the patient has menses. So that's why for such patients, avoid in pregnancy in a later stage to continue cariprazine. But if patient is unknowingly not knowing to you and continuing, you need not panic. The patient will do well. And there are a couple of case reports which has got published also. Okay, they have continued till the term of pregnancy and they had done well, and there was no much side effect with the cariprazine. Lactation, there is not much worry. You can continue with cariprazine. Just we will have to see if the patient is having proper lactation or not, because sometimes it can cause reduction in prolactin levels and all. But I think the effect will be very minimal, and the patient will respond well, and you can continue with lactation also, because the main worry of giving any other antipsychotic can be causing sedation in the mother, and if it go on in breast milk also, but that is also minute quantity, the child also sleeps more. So cariprazine that way is non-sedating, not to worry much, and the quantity goes very less in the breast milk. So I think it is safer to use, but not knowingly. Unknowingly is okay.
Yeah. Dr. Sagar, any person who was pregnant and had continued till the end of term and actually delivered a baby?
Not in my practice, but yes, in literature, we have got one case report that you can just type on Google cariprazine and pregnancy, and that case report comes up easily. I'll just name the author. I'll just say the author in Google. If you just type, it comes. They have two case reports they have published. It's a case series. So cariprazine maintenance treatment during pregnancy. It is by Robert Herold, uh, Frontiers in Psychiatry. Now again, we can just go through, and then patients responds well. In my clinical practice, about 3 months, I have not allowed them to go.
Dr. Sujit, you actually mentioned about the need for slow titration. So, when you're mentioning slow titration, are you trying to say that this molecule may be difficult to use when we have acute exacerbation phase of mania or schizophrenia?
Yes, Dr. Mahesh, definitely. See, there are two possibilities. Actually, the primarily undesirable side effect that I was talking about, or Dr. Sagar was talking about, was obviously akathisia, which comes up early. I personally feel that using it with benzodiazepines also may not be good enough to prevent the initial side effect of akathisia. This was the first premise. And the second premise was that often in lower doses it produces the desired effect rather than going at very high dose. Having said that, I agree with the fact that if I am dealing with an acute psychosis wherein I would ask for a very early result, so therein cariprazine may pose a disadvantage. This part I do agree with you, because I could have given olanzapine 10 or even some cases 15 at the first shot. Here, cariprazine definitely stands at a disadvantage as far as my opinion and experience is concerned.
One more question I had for both of you. Do you have any specific desired combination with an antipsychotic using cariprazine? And if you were to use any other molecule, typical or atypical, do you have any specific choices?
Usually, as I discussed in my cases, I give it with olanzapine or clozapine. So usually it is olanzapine, then second is clozapine, and third will be cariprazine. So this is my usual combination in maximum of the patients. Some patients are on blonanserin with cariprazine. So that is also combination which is seen frequently with my practice. Third thing I would just like to add on with the what Sir Sujit Sir has said that about that fast titration. So some patients, yes, definitely does not tolerate the higher doses. So some clinicians, what have they have done that initially they give one capsule every alternate day till the patient has good response for a couple of weeks, and then they make it a daily dosing. So that strategy also people have used to avoid early akathisia in the patient. So to improve the compliance. So that is one more point I would like to add.
Dr. Sujit, your response on favorite combinations?
You mean to say molecules I would like to combine with cariprazine?
Yes, absolutely.
Yeah, see, for me, I would often prefer an atypical with cariprazine. Usually, the one which is having a which is having a faster onset of action. Say something like olanzapine or risperidone with cariprazine. And actually, my idea would be that in the long run, if the patient responds, ultimately I would be gradually up titrating cariprazine, and and maybe down the line I'll be able to maintain the patient on cariprazine only, which is metabolically friendly for long term maintenance. So it's usually olanzapine and risperidone with cariprazine.
Okay, since any resurfacing of symptoms if also discontinued at times for some significant duration of time. We've had a difficult scenario where this molecule plenfluridol is actually out of market. Have you actually tried to use this molecule as a once a week or twice a week doses?
Yes, this was when particularly when penfuridol, as you discussed, went off the market. So I have many patients whom I have shifted from penfuridol to cariprazine. But here not once a week, but at least thrice a week I have said, because cariprazine we need concentration, and which is actually with at least alternate day or twice a week to at least, because giving only once a week does not maintain that concentration. So yes, can be done.
Okay. Would you say that because it's got this prolactin sparing effect, this is a molecule that could be a preferred molecule like aripiprazole in woman population? Would you say that this would be something like a first line drug? Because this seems to be working in depression, some symptoms of mania, maintenance phase, acute exacerbation phase. So it has varied indications across the symptom profile and spectrum. So would you say this could be a first line molecule for a person who could be of malleable age and who's conscious of side effects and prolactin related issues?
Uh, Not as a first line in all the cases blindly or all the female patient, but all the indications which we had discussed and wherein we can use what I have discussed accordingly in the cases.
Okay. Any sort of precaution using this molecule or any particular symptom profile or a patient profile that you would like to avoid using this molecule?
Only the one who have got a high risk of ectasia, we should be very much worried about, means we should be vigilant. Though it is having a longer half-life, the risk is pretty less, but then we should be vigilant because if patient has already lot of this thing side effects. One thing I would like to mention, a patient of tardive dyskinesia also can be tried cariprazine because the risk is pretty less compared to our other things. Means clozapine definitely is the safer one, but in some patients you can't give clozapine also. So then this cariprazine chips inside very well in such patients also.
Suppose we try and use this sort of side effect profile of medications. It is prone to akathisia, it has insomnia. So can we think of combining low dose clozapine in scenarios so that these issues can be actually avoided?
At the first line, I would prefer to give benzodiazepine freely because in majority of the patients, I give propranolol with clonazepam as a day one only, on day one along with cariprazine. And once he is tolerating well, I would stop. Clozapine, we directly not prefer to give on day one lower doses, particularly for only just sedation or for preventing ectasia, because ectasia is something which gets well responded with propranolol and clonazepam better than clozapine. What I have seen.
आप लोगों ने ऑप्शंस भेजना चालू करो, ठीक है? मेल का वेट मत करो, छुट्टी पे हो। ये
Nilesh, mute yourself, Nilesh.
Any final take-home points for the viewers? When this molecule would be the first line, when it could be second line, when it could be just an add-on?
So first line basically, as we discussed in the maintenance phases where patient is doing well and having lot of other concerns and all, we can start. In depression, we directly may not start cariprazine, because we will always use antidepressants. So again, in these cases also, it will be on second or third line. Means nowadays what we have done is we are trying that whether it can be used as a second line agent after an SSRI. So we are into using in some of the patients after SSRIs. Rather than giving other antidepressants, giving cariprazine, and they have found a good response. So there we can try as a second line.
Okay. This question is to both of you, and I would like to ask Dr. Sujit because he seems to be extremely cautious about doses. What is the maximum dose that you would use for a person with bipolar disorder and a person with schizophrenia? Maximum doses that you would actually use and recommend?
I have a few patients at with 6 mg cariprazine, maintaining well actually. In obviously schizophrenia, bipolar, I have one on 4.5 mg I have used, and subsequently after the episode has resolved, I have gradually down regulated it because it was an adjunct medication, not it was in addition to a mood stabilizer. So this is about bipolar, but schizophrenia I have at least 3 to 4 who are on 6 mg. Majority have responded to 3 mg. Surprisingly, I have a few who have responded to 1.5 mg also, although it was in the early phase of psychosis, but they have responded. So that's why I keep saying that the cariprazine is one drug wherein if you can afford to wait, you will get many surprises. This is what I feel. And number two, I feel just like aripiprazole, since cariprazine does not have that dramatic effect of cutting through the symptoms of psychosis very early in the dosage, so it may not be very sensational to begin with. But if you can persevere, you will see many of the plus points of cariprazine. So probably it is going to be that way. It is going to probably follow the aripiprazole trajectory. With passage of time, many of its newer clinical effects will emerge and will make it much more popular than even if it is today. For example, as Sagar was saying, you can over a period of time, it will probably become one of the adjunctive usage in case of hyperprolactinemia, just like we do with the lower dose of aripiprazole. So over a period of time, it will come that people will start augmenting it with 1.5 mg of cariprazine. So these are some of the areas wherein it will come. So as far as dosage is concerned, I have used at higher dosage, but have not achieved them very early in the course. So those with 6 mg have probably reached 6 mg after almost 3 months. I hope that answers my point of view to your question.
Dr. Sagar?
Yes. Again, as I said, in my majority of the patients, I use 1.5 to 3 mg, and the titration pretty, I do it in 15 days actually. So first 15 days 1.5, then 3 mg, and I am not using much in positive symptoms and bipolar mania. So only couple of patients are on 4.5 and 6 mg. So majority of my patients are on 3 and 1.5.
There's also a question if there are some finer points that you would like to differentiate aripiprazole from cariprazine. On what points does it differ?
So mainly, if you see, the formulation is differing. Mainly, aripiprazole is available in tablet form. Cariprazine is a capsule. So that is the main hurdle. As many of the cases, if you have seen, I have used in children late 8 years and all, and some elderly. So where the capsule means swallowing the capsule is a difficulty. But off-labelly, I would like to say that I have used it in the powder form. Like I'll open the capsule and give the powder to the patient, and that has worked well without many side effects. So you can use the powder with removing the capsule. Secondly, coming to the side effect profile, akathisia, I have seen pretty less with cariprazine, but more with aripiprazole what I see. Third, the dose titration is easier. Here 1.5 and 3 mg aripiprazole, you have to go to 5, 10, 15, 30, means you have to go at a higher dose, and ultimately it causes more cost to the patient. Here it is a more cost effective therapy, means 1.5, 3 mg is pretty reasonable rate and the patients can afford well. So these are my couple of points on this.
Sujit, your take on this?
See, I personally feel that aripiprazole, in terms of subtle effects, I think aripiprazole would, considering a relatively less time of usage of cariprazine in India, although it is not that newer molecule. If you look at the global scenario, it was, I think, 2015 or 16, I think it got, 13 or 14 that it got FDA approval. So that way it is not very new, but in Indian scenarios, just maybe around 2 years or so. But then also, the way it has shown promise in bipolar depression, this is one area where I feel it definitely has an edge over aripiprazole. So the depression part, yes, aripiprazole does have its effect, but probably this is one area where cariprazine definitely scores hands down over aripiprazole. Other areas, yes, as Sagar has said, the dose titration is easier. In fact, aripiprazole used to cause a lot of akathisia even in those who, in which we would begin with 5. And then that brought 2 mg aripiprazole in the scenario. And many times now we start off with 2, and that has significantly reduced the incidence of the initial akathisia. So dose titration is definitely easier with cariprazine because it has only 4 possibilities. But yes, efficacy-wise, aripiprazole has still reached a broader spectrum in terms of both positive symptoms and also autistic spectrum, so many uses. But for bipolar depression, this is one profile where I feel cariprazine has a better, efficacy.
And looking at what Dr. Sagar presented, he's actually used across the spectrum in terms of age, in terms of initial disability, behavior is another thing that he talked about, and personality disorders. And across the symptom of emotional instability and impulsivity is what he also talked about. So would you think that because of the side effect profile, cost effectiveness, and also some sort of efficacy in these sort of scenarios, would it stand out as at least a first line molecule for indications like personality disorders?
See, it is very much possible. In fact, I don't see any irrationality in Dr. Sagar's off-level usages, because see, as you would be knowing that many a times approval process is something which involves a lot of red tapeism across different drug controlling bodies worldwide. That is one thing. Another thing is extrapolating the indications based on the previous use of similar antipsychotics with similar profile. So look at autistic spectrum disorder. Fine, risperidone and aripiprazole are the FDA approved ones for irritability. But what should prevent you from using, at least in the younger, I mean the older adolescents, should not prevent much from using cariprazine. Same with emotionally unstable personality disorder patients with episodes of violence, or for that matter, augmentation of OCD. See, these are classical cases where antipsychotics in general and aripiprazole in particular have established their efficacy and usage and also developed evidence. So it is just a matter of time, as I was saying, before cariprazine also chips in. So that way, using for these kinds of indications, when especially with initial positive results, I see a lot of promise for cariprazine. I think it will almost cover the similar gamut of the entire gamut of indications that where aripiprazole has established itself, and probably go a bit higher in cases of bipolar depression and also negative symptoms. Probably negative symptoms, this is something which I thought I will mention but I forgot. Basically, you look at one of the cases presented by Dr. Sagar, it is a matter of time, because we have classically, because of evidence only, habituated ourselves with by chipping in amisulpride wherever clozapine provides a certain amount of response in the positive symptoms, but the negative symptoms seem to linger on in the patients. We very frequently use amisulpride primarily because of its evidence on different meta-analysis. Here, it seems that cariprazine holds a definite promise. I cannot say for sure, but to me, it seems that it's over a period of time, probably cariprazine will become an important player in this area, wherein clozapine has caused a good amount of response to positive symptoms, but negative symptoms are there, and you need to augment clozapine. So probably cariprazine is going to play a very promising role here.
I'm actually fresh from a discussion from Dr. Badamat's talk on medical negligence. So in the specific case that he talked about, it was about Montgomery's case. He specifically mentioned that you're using off-label indication, but if you're not backed by clinical practice guidelines, in terms of legality, this may not be, really acceptable for the courts. So, since you're also in the office of the EC and IPS, some attempts have to be made to make sure at least this sort of off-label use of cariprazine would be somewhere down the algorithm to say that this could actually be tried in some ways. In general, saying atypicals is still a good indication, but talking particularly about a molecule like cariprazine, if it can find some place in the CPG guidelines of IPS across the indication, I think it would really strengthen the hands of a prescribing doctor in terms of legal scrutiny.
Yes, I agree fully. I mean, we these days we have to restrain ourselves whenever you have an urge to, because if you go by the principle of premium non nocere, so ultimately, if you inadvertently cause some harm, then no one is going to spare you. I agree, and probably over a period of time, we should develop at least some level of evidence, even if it's level 4 or 5. At least that should, if that finds a place in the guidelines, that will give some breathing space to the clinicians. I absolutely agree with you.
Sagar, your take on the off-label uses, in case we don't find mention, how do we actually circumvent, and how do you find this sort of support from literature for?
Yes. We get a lot of literature. Like I just said, in pregnancy, when my patient got pregnant, I just Google search and I got at least 2 case series, like case reports which were published. So I was heaved a sigh of relief. Similarly, there are so many case reports of borderline personality disorder or autism where we can show as an evidence that there's in foreign countries that has been tried and off-label is allowed. Means And in the last, we can call Dr. Mahesh Gowda or Dr. Sujit sir and myself as an expert witness. Yes, in clinical practice we have used. That is the last option for the clinicians in case if it happens.
No, actually, what the code actually looks at is like, evidence in the form of mention in CPG guidelines, approvals from authorities like FDA, or what do you call standard of care from a professional body. So,
yeah, that is there,
professional
but then
body.
say no, we can show that evidence will only come when there is a lot of literature, and then only it will find its place in guidelines. Like in guidelines, there are some molecules which are now off the market, so we can't say now where will we use those molecules. No, so that is always be there.
I think there are no other questions in the chat bot, and I think we covered most of the issues, Dr. Sagar and Dr. Sujit. I think we would definitely agree that this was very productive discussion, talking on various aspects of not so commonly discussed issues about this molecule and the utility of this molecule. I would take this opportunity to thank Dr. Sagar and Dr. Sujit for sparing their valuable time for educating us all. And I would like to request the sponsor to have the last word in the discussion.
Sir, very happy from Hetero Healthcare, sir. There is a wonderful presentation and a good deliberation, sir, which is a very big feast you have given to the audience, participants, the doctors, and a lot of questions also. It is very interactive, very practical. Thank you so much for your insights. And it is absolutely everything is line by line is practical. Not anything is bookish. And it is a real wonderful presentation, sir. Thank you very much. And an excellent moderation, sir, Mahesh Gowda, sir, and Sagar, sir, and Sujit, sir. Our heartfelt thanks to you and your wonderful time you spared for us. And on behalf of Hetero, we say once again a big thank you with a lot of gratitude.
Thank you.
Thank you.
Thank
We
you.
began on time and we are concluding on time. I think it's a very nice
Yes, yes, sir.
learning for all
Yes,
of
sir.
us.
Yeah, yeah.
Thank
8 we
you.
started. Yeah,
For
yeah.
the
Yes, sir.
program end.
Yes.
Thank
Thank
you.
you so much, sir.
Thank you, everybody. That's all from my end. Thank you, Dr.
Thank
Sujit
you
and
so much,
Dr.
sir.
Sagar again.
Thank you, Dr. Mahesh and Dr. Sagar, and the team from Metro. Thank you.
Thank you
Thank you
so
so
much.
much, sir.
Yeah, Jayant, we can